we have a recording by Dr. Abou-Alfa, who is actually here, and he will be able to answer questions live. So we will, as we get ready to prepare this video to show everyone.
Thank you again for joining, and it's a great delight to be all together again this year. The big thanks, of course, for the American Liver Foundation for giving us the opportunity to be all together. Unfortunately, I'll not be able to join for that part in person, so that's why it's this recording. But of course, look forward to engage with all of you with any questions or any comments that you might have. So, no doubt that I was tasked with in regard to the emerging treatments for liver cancer will, of course, depend on a perception that we all should have to kind of make sure we take the most out of it. And the question is, what's our purpose when a dear patient has liver cancer? The patient purpose is very specific: want to live. Living is key, and that's why we really need to make sure we look at all that data from a living perspective and keep alive, and not only keep alive, but keep functional while we're alive. Liver health, as we heard from my colleagues, is very critical and important to recognize that there are many risk factors that can lead to liver cancer. Please do remember that some of the risk factors might be related to certain experiences or behaviors that we had in life. Please don't ever be judgmental for your dear friends or loving ones. We are with the disease now. Let's focus on the disease itself. But by all means, we'll make sure to maintain liver functionality to the best health possible so we can benefit from the therapies that are available. So what are the therapies? No doubt that thankfully today, we can proudly say that we have many options of treatment. Your doctors will talk mostly to you about immunotherapy. Immunotherapy implies that we're trying to use your own immune system to fight the cancer, and as such, trying to neutralize its activity, its abilities. The way it's done is with different variation of treatments. You probably heard about a lot of them with kind of like long and a little bit complex names, but among which I'll name few. For example, you have the atezolizumab plus bevacizumab. You have the durvalumab plus tremelimumab, and you might have also single agent like the pembrolizumab itself. We have to remember that these are not necessarily the only options of therapy. Some of our dear patients might not necessarily be amenable to get the immunotherapy because they have other immune-related diseases, like, for example, E. colitis, inflammation in the bowels. And as such, we have to depend on some other form of therapy, which, as we know, they're what we call biologic or targeted therapy, or what we call tyrosine kinase inhibitors, among which two of them that really are mostly used as a first-line treatment, i.e. patients with new advanced liver cancer that needs systemic therapy, are sorafenib and lenvatinib. Now, how to pick and choose? By all means, there's a lot of ifs and buts about all those therapies. I would respectfully defer to your discussion with your doctors, but make sure you get the most objective opinion you can. And to be fair, liver cancer is not that common, and as such, experience might necessarily be always to be the one that you aspire for. Ensure that your colleague, your doctor rather, talk to his colleagues or her colleagues, because they might really benefit from this interaction. And of course, if you have to get another opinion, it doesn't really be valuable for you if necessary. So, but if you decide to do that, please work with your doctors. Don't really just do things independently of your physician. Another important thing is that if the therapy is not to work in first line, we have, of course, second line therapy. I'm simply lining them up over here, among which, for example, is what we call regorafenib. We can talk about what's called cabozantinib. We can talk about what's called ramucirumab. And of course, immunotherapy itself might be revisited by your doctors as well. You'll notice in all what I spoke about, chemotherapy does not play a role except in very rare instances regard to liver cancer. By all means, though, clinical trials continue to evolve, and we need clinical trials because all those names of trials of correction of drugs that I just lined up for you are dependent on clinical trials that were given beforehand. So we have to be very grateful and very thankful for all the patients who contributed to those clinical trials that led to those drugs being available to all of you. And as such, if you are offered a clinical trial, by all means, discuss it with your doctor, learn more about it, and this make, of course, a conscious decision. But don't ever think you are obligated to do that. If you feel like this is not for you or it's not what you're interested in, of course, this is your opinion and you're have full right to take care of that. And I can assure you, all their colleagues, all physicians are very capable of respecting that opinion, continue to provide you with the best care possible, independent of your decision to go on clinical trial or not. On the other hand, of course, if you see that, yes, it's an opportunity, I value that therapy, why not? After all, this is really how the science of liver cancer will evolve and continue to evolve. To continue to look a little bit more into the different therapies, and I'm trying to connect the dots of the three things I spoke about, which is the purpose is to live. This is what we call overall survival. And number two is the concept of liver functionality, which we relate to what we call cirrhosis. And you might hear the word called Child-Pugh scoring with your doctor, which means related to liver function, and of course the choices of therapy. Please, very important that we don't live for the CAT scan results. In other words, our life is not dependent on that. Our life is dependent on being functional, doing things, and living. And please, as such, I don't expect, and I don't like to kind of, see you ultimately living from one scan to the other. This is not the point. The point is to live and enjoy life and do what you really are interested in. And this will translate ultimately in overall survival. And as such, the CAT scans are nothing more, or the MRIs or whatever imaging your doctor decide, are nothing more than simply a benchmark to confirm, yes, we are on the right path per se. A very important point about the novel therapeutic involvement is that not necessarily that we're going to see what we call smaller means better. In other words, shrinkage is, yes, can happen, and of course we like it, but remember, stable disease is also appropriate. It means that the cancer is not growing, you are keeping it at bay. And definitely this is something to celebrate as well as a good result. Again, within the context that, as we said, celebrating means being alive and coming to the doctors. I always jokingly say, one time I have to say, one patient really kind of cornered me and said, what's survival? And I said, the more you see me, the better you are. It doesn't mean like for me, but in other words, the more you come to clinic, the more you get care, the more you're living, the more you do things, of course, the better you are. And that's exactly what survival is. Keep going. Within that context, trust your body. Your body can a lot of clues in regard to what the therapy might be doing. And this is where we have to differentiate between what's called allergic reactions, adverse reactions, or side effects, and of course also what could be disease related. Usually allergic reaction will happen immediately as therapy is given. Thankfully they happen rarely, but they can happen. So doctors will be, don't worry, next to you. Your caring team, including the healthcare workers, including nurses, will be there to kind of assist and understand very well what are the ramifications of that. On the other hand, in regard to the adverse reaction they can occur, immunotherapy by itself can cause some adverse reactions. They can be very subtle, among which like joint pains, some rashes, some diarrhea. Of course, we don't like them, but now we know that if you are activating the immune system, it means that it's working. By all means, the benefit from the therapy will be even more. And as such, don't be kind of, worried if some subtle reactions, not that we like them, but they could be implying that the immune system is doing the job. Now that we look at the book picture again, I'm going to take the time to revise one more time the drugs now that you already feel more comfortable in regard to the context of what the discussion is about now. And I just line them up in certain sequencing because it's important what we need to know about as well. As we said, immunotherapy is first line. Combination immunotherapy is very important. We gave some example, among which, as we said, the atezolizumab plus bevacizumab, among which also durvalumab, tremelimumab. Very critical. If you decide the first option, if your doctor decides the first option, you need an endoscopy because there is a chance you can bleed because of the drug called bevacizumab. Very important. On the other hand, your convenience might be measured by other things, like, for example, you really would like to travel in between, what have we. This, for example, were durvalumab, tremelimumab. The other choice can offer a very infrequent therapy, which is like only once a month, with one of the drugs, the tremelimumab, given only once. Now, the other two choices of therapy that I spoke, sorafenib and lenvatinib, as I mentioned, there could be options for patients who really cannot get immunotherapy. But on the other hand, let's assume patient got immunotherapy and they need another choice of therapy. Do we jump right away to the other choices I've given as what I called second line? Not necessarily. We can use still those other options like lenvatinib before move on to the second line therapies. And the second line therapies, some of them certain requirements are needed. Cabozantinib, no issue at all, can be applied after any treatment, could be even used as second or third line therapy, the only one as third line therapy. The regorafenib would require prior sorafenib exposure in a good tolerance to sorafenib, progression of sorafenib before getting it there. Ramucirumab will require a certain marker called alpha-fetoprotein being first above a certain level of 400 to be eligible for the therapy. And of course, pembrolizumab is another immunotherapy that can be used as we decided whenever either it was not offered beforehand or for whatever reason the doctors feel like now it's time to do another immunotherapy. To again, one more time summarize, trust your body, have faith, and by all means, entrust that systemic therapy is ongoing at a very robust path at the moment. And this is thanks to all of the patients who really were engaged in the clinical trials that we have done and led to where we are now, that we can, yes, not only offer one option, two options, actually many, many options. And I thank you very much for listening. I look forward to engage with you. And thanks, Anne, for your attendance today.
Hi, Dr. Abou-Alfa. Thank you. I'm so glad you're able to join.
Oh, thanks so much, Michelle. So delighted to be here. Thank you.
We have a couple of questions for you. The first is liver stem cell therapy in practice? And how effective is it when associated with other therapies?
So stem cell is not yet in practice, but it doesn't mean that it won't be one day. We're still kind of like evolving to understand better stem cell therapy, anything that really will make even the tumor not only being seen by the immune system, but rather even smelled by the immune system. We're not there yet, but doesn't mean that, but a lot of work is going on in many sites, including here at Memorial Sloan Kettering, that will hopefully get us there. But we just have to, wait until it's really mature enough to talk about it as a standard care therapy.
And the second question is it normal to switch therapies if the first is not working?
If the therapy is not working and we need another therapy, it's not only normal, this is the right thing to do. We have to really move on therapies to make sure that we should not take this as being like something that's bad. Absolutely not, because these tumors, same way we're trying to fight them, they're trying to fight the treatment as well. And so resistance to the therapy might happen, and this is where you change therapy or you change strategy, in other words. Very important, though, that we should not change therapy except if we really have a no response or a cancer is progressing, or because of a intolerance to the therapy. But to just switching therapy just because I'd like to this, I like that, not a good idea. You want to really max out of every therapy to the best possible before you change to something else.
Right. The third question is, what are the chances for success with the planned treatment? I'm not sure if that's...
Well, I'll take it and will answer to every patient. The chance for success for them, they should focus on only one number, is 100%. Because we cannot play statistics. None of us, and especially our dear patients, they're not statistics. They are really living and they are doing their best, and we have to really give it all full faith the best we can for them. I've been doing this for almost more than 2 decades, and I can tell you, if it wasn't for the faith that patients teach us, we wouldn't really be able to talk about now incredible improvement in outcome that we're seeing. When we started all of this, we're not even talking about like a few months of outcome. And look, now we're talking about years of positive outcome. So by all means, patients should really maintain their faith and think about this. I'm going to beat it to the best possible. If anything happens that's really sadly not good, don't worry. doctors are very capable of talking and bring it up before even you would worry about it. But we should not live at this being the cautious approach. A more positive approach will always be very uplifting and helpful for all of us. And to be fair, it's really very doable nowadays. We are seeing really incredible outcome from all those therapies without any exception.
Absolutely. And the last question here is, how will treatment affect my daily life? Will I be able to work, exercise, and perform my usual activities?
Well, you should. That's exactly what I focused on in the lecture. After all, we're trying to treat the patient. We're not trying to treat the cancer. And as such, yes, to treat the patient means that the patient has to have the cancer under control, but at the same time, the patient should make sure that they are able to perform their daily life activities, as you just mentioned. As I mentioned, as an example, like with the durvalumab, tremelimumab, which was called the STRIDE, or based on the Himalaya study, the therapy is really given every month, only once, and patients just going on with their lives. I'm going to give a little bit of an anecdote, which is really kind of like really very uplifting. Two of our dear patients at Sloan Kettering bumped into each other somewhere, somewhat in the world on vacation, and they're both on the same therapy. And they're making like, I mean, this tell you how much people are able to live. So by all means, people are very capable of continuing their lives. And at the same time, if adverse events happen or side effects happen, please call your doctor, talk to your doctor about it, and we'll try to manage it to the best possible. We're not going to say it's perfect as if nothing is going on, but many of it can be mitigated and really be kind of, taken care of one way or the other, enough to keep the patient going within the context of having cancer, but still able to really manage those side effects.
All right. And there's one final question. It just came in. What types of therapies and innovations are on the horizon?
No, that's a great question. And by the way, I'm happy to answer others, but I, of course, defer to you, Michelle, and for the ALF if really there's time. Regardless, this is a great question. What's new? There's a lot going on these days in regard to the therapy. Number one, as you noticed, and to be fair, this is really where the whole disease treatment is. Immunotherapy is really a very important scaffold, or what a reference point for how we take care of patients. Within that context, we have noticed that at the moment, the advancement of the immunotherapy for even enhance it further is definitely a way that the venues are going on to a better outcome. On the other hand, what we just referred to in regard other approaches that really manage the immune system, being like cell therapy, stem cells, vaccines, are on the horizon, but not there yet. So I would say there's a lot of innovation going on that will continue to evolve in that regard. Now, within that context, though, a very important point is, remember, we're treating all patients the same way at this point in time. Patient liver cancer, confirmed liver cancer, we just treat with the same disease. But now we know very well, because the different risk factor that developed or caused the development of the liver cancer, being, of course, the potential viral infection like hepatitis B, hepatitis C, or what we call non-viral collectively, or the non-fatty liver disease, or what you call MASH nowadays, or alcoholic liver disease. These are really the risk factors. Now we know very well that they might actually differ in regard to how to make us respond to therapy. Number two is, we know very well that ethnicity might have an impact. We know that other variables in regard to the immunotherapy, or what we call the immune microenvironment of the tumor, can differ. So we hope that actually not only finding new drugs, but be able to come to a patient one day and saying, rather than you have a certain % chance that you might respond to the therapy because you have 1, 2, 3, 4, 5, 6, whatever number of variables, giving that therapy, we guarantee that you'll respond. That's what we hope for.
Absolutely. Well, I think that concludes our Q&A session. So I'll hand it back over to Ms. Allison.
Thank you so much, Michelle, and thank you so much, Dr. Abou-Alfa, for a great presentation and ending. I truly want to thank everyone. We did go over about 20 minutes, but we had so many questions coming in. And so I have to just thank all of you, our presenters, for staying on a little extra, and to our audience who has some incredible questions. This truly was a conference for the patients and caregivers. And so we are just glad that you were able to get as much information as you needed today and to stay a little longer to answer your questions. I wanted to let you all know on Thursday, October 26th, we have our feeding, which is a great program, Feeding Your Liver, Fueling Your Life, featuring nutrition specialists from Meyer Specialty Pharmacy. And you can register at liverfoundation.org. The link is in the comment section. I also want everyone to know that we have our liver cancer Facebook group. The link for that was also in the group. So many of you are part of that. It's a great place for you to connect with others, ask questions, and really build a community there. And so we have this for many of our patients, our caregivers, and also medical professionals sometimes join in. So it's hopefully a place that you guys can feel like you're building a community and you have others to connect with. And I just want to say thank you again. What a full day for a conference. Thank you again to all our speakers for spending this time educating us about liver cancer and providing such valuable and informative information. I hope all of you found this program helpful and learned a lot.